Ladies and gentlemen, we present a case of a 53-year-old gentleman who was incidentally found to have an aortic aneurysm and a bicuspid aortic valve with moderate AI. The operative CT scan shows a 5 cm ascending aortic aneurysm and a normal aortic arch. The femoral vessels were exposed on the right side, and routine cannulation was performed under TAE guidance. A right anterior median thoracotomy was performed in the second intercostal space. A CO2 line was inserted, along with a soft tissue retractor and a rib spreader. The pericardium was opened, and stay stitches were applied to improve exposure. Cardiopulmonary bypass was initiated, and cooling was begun. Once the heart fibrillated, a cross clamp was applied and cardioplegia delivered in the antegrade fashion. The right atrial appendage was retracted to improve exposure. Next, an aortotomy was performed. The valve was exposed using stay stitches, and valve excision was performed in a standard fashion. The valve was then sized to a 27 mm mechanical aortic valve. Once we reached a core body temperature of 25 degrees Celsius, the pump was stopped and the cross clamp was removed. The aneurysmal segment was dissected and excised. A balloon-tipped catheter was inserted into the innominate artery under direct vision, and ACP was instituted. The distal anastomosis was performed in a running fashion using a 4-0 proline. Once the distal anastomosis was done, the pump was gradually restarted and hemostasis was checked. The graft was then transected to the appropriate length. Pledgeted valve stitches were used for the aortic valve. The valve was then brought down and secured with a core knot. The proximal graft to aorta anastomosis was performed using a 4-0 proline in a running fashion. After de-airing, the cross clamp was removed and the heart began to beat spontaneously. Decannulation was then performed in a standard manner. Next, a multi-level nerve block was performed in order to achieve adequate postoperative pain control. The femoral vessels were repaired, and the chest was closed in multiple layers. The patient did really well postoperatively and was discharged on postoperative day 6. A pre-discharge CT scan was performed and it showed no abnormalities.